we'll do a quick quiz about cardiology. We didn't get to do that quite yet. And then we will move on to the second respiratory lecture. We should hopefully get done today. Hopefully, we should. All right, so kind of picking off where we last left, we're going to talk about sarcoid. Now, sarcoid is one of those weird things, right? So there's also granulomas involved with this, right? We talked about TB and how TB can cause you to make granulomas. This guy here with sarcoidosis, this can cause also cause granulomas formation. But the thing with this is that there's no infection, right? There's no TB, there's no bacteria, there's no fungus getting into the lung. For some reason, the body starts making these granulomas without any specific triggers. So it's an autoimmune disease, right? This disease process can affect multiple parts of the body. It can affect the liver, the brain, all organs, right? But primarily what we're worried about is the lung involvement. When we get these granulomas that form in our lungs, these macrophages come, right? Macrophages come, and I told you guys about giant cell arteritis, and I talked about this kind of briefly last block, how these helper T cells tell the macrophages to get stronger. I don't know if you guys remember that. Get stronger, become more powerful, and those are called epithelioid cells. When these epithelioid cells merge, they form these giant cells, and that's where that giant cell arteritis comes from. This is the kind of the same process. These macrophages, they get stronger, they merge together, they form these giant cells, and these giant cells actually are what help cluster, what will cause those granulomas to form, but there's nothing inside of them. There's nothing inside of them. It's just a kind of a ball of immune cells. And because there's nothing inside of them, there's none of that caseous necrosis that you would see with TB. You don't have the dead macrophages, you don't have the TB kind of trapped in there. There's nothing in there. So we call these non-caseating granulomas. The thing with this is that most of the time, you may catch this whenever you're just working up a patient for some other reason, right? The patient's not going to have symptoms. You shoot a chest X-ray, and they got what's called hilar lymphadenopathy. They have in their hilar region, we have lymph nodes. Right? We kind of talked about that last time. Those lymph nodes become enlarged. You have granulomas that are forming. The granulomas, though, are so small that when you shoot that chest X-ray, you're not going to see them in the periphery of the lung like you will with TB. You're just going to see that hilar lymphadenopathy. Those granulomas are actually in the lung. You just can't see them because they're so small, but they're actually in those lymph nodes as well. So when you shoot the chest X-ray, you don't see the granulomas on the periphery. You don't see the granulomas in the lung tissue. But what you will see is that bilateral hilar lymphadenopathy. And that's how when we see that, and we see no other symptoms essentially, that's when we start thinking that this person may have the sarcoidosis. Now, some people will have symptoms. They'll have fever, fatigue, anorexia, trouble breathing because we're getting these little granulomas that are in the lung tissue. And you got to think, if you have something, some type of something that shouldn't be there, and it starts distorting that lung tissue, they're going to have respiratory symptoms. The way we kind of determine is this truly sarcoid? Well, you want to try to get a biopsy of that granuloma. Typically, we'll go and we'll do a lung biopsy, try to see if we can identify a point that has granulomas, or actually go into the lymph nodes themselves and take a biopsy of that. The good thing about this is that most of the time, this is going to go away on its own. It kind of comes on its own, and then goes away on its own. So you're following a patient, or they're following pulmonology. Essentially, they're going to be seeing a pulmonologist, and then all of a sudden, they're going to get better. Sometimes it doesn't, and so sometimes pulmonology will treat these people. They'll give them steroids. They'll give them other types of medication to kind of lower their immune response. But most of the time, these guys get better on their own. So here's that picture of kind of what that looks like. So you see on the left-hand side that this chest X-ray is normal. And on the right, you kind of see in that hilar region, you just got a bunch of stuff there, right? You got a bunch of these this white, kind of consolidated looking appearance. That's those lymph nodes that are enlarged. But what you don't see are those small granulomas, right? Because they're too small to be picked up on chest X-ray. If you did a CT scan, you'll be able to see. But we're not going there. We're not kind of getting that far. But if you see this, if you see bilateral hilar lymphadenopathy, and nothing else on a chest X-ray, that should prompt you to consider that maybe this is some type of sarcoidosis disease. Cool. All right. Let me switch here. Any questions about that? No? So a quick refresher quiz on cardiology stuff. When I finish home today, the next time I see you guys, we'll do a quick home quiz. So we're gonna kind of start off easy today, and then kind of move our way towards what you should expect to see on the exam. So we got cardiac muscle, distal to an 8% occluded coronary artery makes initial experience which of the following? D, ischemia, right? So if you have some type of blockage there, those cardiac cells are going to become ischemic first. Eventually, if there's a complete blockage, or if that ischemia is there for a very, very long time, that can lead to a infarction. And remember, we talked about in the slide that typically you won't start experiencing that angina pectoris until you start getting 7% occluded. All right, so which of the following are associated with coarctation of the aorta? Yeah? You like that? Yeah, makes sense, right? So if we have that coarctation, we're shooting a lot of our blood to our upper extremities, through that aortic arch and those branches. Down below, you're not shooting as much blood, so if you check somebody's brachial or radial pulse, at the same time we're checking that femoral pulse, you're going to feel this pulse first, and then you're going to feel this femoral pulse eventually. It's going to be a few seconds delayed, but it's not going to, typically when there's no type of blockage, right, or coarctation, you should feel that pulse pretty quickly at the same time. With these guys, there's a delay in that, okay? These other ones, the pulsatile abdominal aorta enlargement, what would you see that with? AAA. Why not JDD for this guy? You don't have the backup, right? That's on the opposite side too. You don't have that backflow. It's all coming on the aortic side. Dependent rhubarb, what do we associate that with? You get color change with that, but we talked about this with peripheral arterial disease, right? You don't have blood, so claudication, you start seeing that you put that foot down and it's red, and you lift it back up and it turns pale. That's that from the rhubarb. Lower extremity hemosiderin deposits. Remember that? No? It's that stasis dermatitis with the varicosities. Remember that blood flow is kind of getting blocked, and so we start pushing out red blood cells, they go into the dermis. So, you'll remember about time. Okay, get a little bit more harder. So, a 71-year-old male comes in with recurrent chest pain whenever he tries to play tag with his grandkids. The pain is relieved whenever he stops playing. What form of angina does this describe? Stable, right? Why not Prince metal? Right. Well, Prince metal is kind of this just kind of occurs randomly, typically at night. It's associated with smokers, right? Unstable angina. Right, going away, right? He plays and then he stops and it goes away. We didn't talk about variant angina. So if you saw that on the test, why would you pick it? All variant angina is just another word for Prince metal. That's all that is. But if you didn't see it on what we talked about, see it on the test, we didn't talk about that. Move on. Okay. Patient with decreased cardiac output from the left ventricle would first develop which of the following? Pulmonary edema. Makes sense. If we're not pushing out that blood flow on the left side, things are going to start backing up. Can you get, now eventually once that right side of the heart starts to fail, can you get the other stuff? Absolutely. But first, you're going to get that pulmonary edema. All right. I'll go ahead and read this one. Yeah, so Charlie, right? So if you now I will tell you on the tests, there's not going to be any except that kind of stuff, right? It's like, it's gonna be straightforward. I'm not gonna try to trick you guys with like, tell me, well, all, I don't, that kind of, it's kind of tricky testing, but. Yeah, we talked about with hypertension, definitely can accelerate atherosclerosis, it starts to damage that endothelium. We talked about how it can damage the small arteries of the eyes and the kidneys. Now diabetes can accelerate hypertension because if you have high blood sugar, that can also cause damage to the endothelium, which can cause plaque buildup, which can cause that stiffening. So vice versa, yes, but hypertension itself is not going to increase the risk of diabetes. Definitely can cause aneurysms. Talk about those saccular aneurysms, the Berry aneurysms, right, or the abdominal aorta. And then with hypertension, if we are, again, kind of causing damage to the endothelium, we're making that endothelium more permeable, which is going to let that LDL in and cause that whole plaque buildup process. All right. You're not thinking. Is that like it? Does that make sense why I say? So this is one of those questions, right? This is definitely something that you could see on an exam. It kind of makes you think, okay, you got to know first you got to know what the disease is, how that disease process works, right? Then you got to kind of put two and two together and then think about, okay, once this child squats, those test squats, right? What are we trying to accomplish there? So whenever we have these test fails, we're getting that increase in that cyanotic flow, right? So this child is going to have to squat down. They're going to squat down, try to kink up their arteries, so to speak, try to reverse that flow, reverse that shunt. Now, when we have that right to left shunt, right? When we have that right to left, what kind of is it? I don't know if you guys remember. I kind of alluded to this. What type of is it? Cyanotic or acyanotic? Cyanotic, right? So acyanotic just means that there's no cyanosis. Cyanotic means that there's cyanosis. So this is a cyanotic shunt, right? It's a cyanotic process. Cool. Questions about any of that? Go ahead.
Is the ventral septal or the ventricular septal defect the most common cause of nephrology?
It's part of it. It's a part of it. Yeah. So you got those four, right?
Right.
Yeah. Yeah.
I'm not sure I apologize.
Very good. Cool. Switch. Alright, so moving on to respiratory system part 2. So here we're going to be talking about the obstructive pulmonary diseases, so asthma, COPD, emphysema, chronic bronchitis. We're going to talk about ventilatory disturbances, talking about acute respiratory distress syndrome, some kind of weird process called pneumoconiosis, where you kind of get these foreign particles in your lungs which cause issues, and then we'll talk about lung cancers as well. So, when we talk about obstructive pulmonary diseases, one of the first things that we want to know about is asthma, right? You guys are definitely going to treat asthma. There's a lot of asthma out there. There's a lot of asthma in our kids, in the military population, so this is something you're definitely going to see. When you get into pulmonology, they're going to go into more detail about this. This is just kind of exposing you to it, but there's a lot that kind of goes into asthma. But with asthma, most of the time, with asthma, they're going to present us as, they're going to develop this as a child. Can they develop it in older age? Can they develop it later in life? Absolutely. I remember one time when I first started practicing, there was I think he was 50 or 60, who never had asthma in his life, and all of a sudden developed asthma. So it was weird, but it can happen. But again, most of the time this is going to occur in children. But what's happening here is that for some reason, the bronchial trees, or your bronchi, your bronchioles, are super sensitive. They're super sensitive to the outside world. And when you breathe in some type of antigen or maybe cold air or something, right? It stimulates those mast cells, which are inside the bronchial tree. They're inside the wall, to kind of kick off, right? When those mast cells degranulate, they release inflammatory molecules. They release prostaglandins. They release histamines. They release leukotrienes. When they do that, they cause that bronchial wall to spasm. They cause it to spasm, which means you go from an area like this, nice, wide opening, to a narrow, right? Not only does it cause the bronchial wall to spasm, but it also causes the bronchial wall to start increasing its mucus production. So you start having this mucus build up. So now you go from a nice open airway to a more narrow airway that also has mucus in there. With that, we worry about somebody having what's called an asthma attack or asthma exacerbation. So you can have asthma, right? You can have asthma and not be experiencing an exacerbation, but when something triggers that bronchial tree to start becoming hyperreactive, these people are going to get very short breath. They're going to start coughing because they have all this mucus in their airway, and they're going to have wheezing. And that makes sense why they have wheezing, right? If they are breathing out and we're pushing on that airway, we're making it more narrow as we exhale, you're going to hear that wheezing with expiration. So the person's breathing in, you may not hear wheezing as much. You probably shouldn't hear any wheezing unless it's very, 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 very severe. But typically you don't hear wheezing, but when they breathe out and we make that airway more narrow, that's when you're going to hear that wheezing. Now, why do we care about asthma, right? Well, obviously asthma attacks are not fun. If you've ever seen somebody with an asthma attack or had a child with asthma, they're not comfortable. And so we definitely want to try to prevent that from happening. But what we really care about is if we don't control asthma, if we don't treat asthma, this is a chronic process. This is a chronic process, meaning they're always having some level of inflammation. With chronic inflammation, that can actually cause permanent damage to the airways. It can cause those bronchial walls to really kind of stay constricted, right? Because what's happening is those muscles, those smooth muscles around the bronchial wall, they start to hypertrophy, they start to get bigger. It's going to make that space more narrow. You start making more mucus. When that happens, if you don't control that asthma straight off the bat, then it's going to be a lot harder to treat that later in life because it's going to make that airway more responsive to whatever triggers that thing to go off. So this airway remodeling is what we're trying to avoid because once that process starts, you can't reverse it. And this is why people die from asthma because they're so uncontrolled, their airway has adapted so much so that when something kicks off an asthma attack, it's very, very hard to treat these guys. Now I'll tell you, this is one of those things that patients don't know, I don't think, because as I became a PA and kind of learned as I went along, that was something that I didn't tell patients off the, right off the bat. I didn't tell them. I just told them, hey, we need to treat your asthma because we want to try to avoid this asthma attacks that your child's having or that you're having. When I started telling patients, if we don't control this, this is going to get worse. It's going to be harder to treat, and you could potentially die from this. When I started giving that last piece of it, that's when people started having more buy-in and start taking their medication. Because a lot of patients, you'll see, are non-compliant with their medications. And so if you tell them, hey, take your medication, you'll feel better. Because sometimes people who have asthma, they feel fine. They feel fine, they're not having issues. Why do I gotta take this medication? If you explain to them this is a chronic process, even if you're fine, your airway is still inflamed. And so if we don't treat this, if we don't control this, it's gonna be a lot harder to, and then, like I said, you could die. Once you tell them that in piece, you potentially could get more buy-in. But does it always work? No. But it can help, and I've seen it kind of shift that way whenever I started treating patients with this. But how do we treat this, right? So one of the things we want to do, especially when they're having those acute attacks, is give them some type of bronchodilator. So albuterol, you've heard of albuterol, right? Albuterol, when they take this medication, it helps that airway relax, so it opens up that diameter. But albuterol doesn't stop the inflammatory process, right? Because the real problem here is the bronchospasm, but the inflammation. The inflammation is the real problem. So typically, we're going to give some type of inhaled steroid. One of the most common ones you're going to give is something called Flovent or fluticasone. It's a very kind of mild kind of the first step medication. But these patients will take this fluticasone, this Flovent, and its job is not to open up the airway like the bronchodilator will, but to calm down inflammation, to prevent that chronic change. Sometimes we'll give mast cell degranulation, or we'll reduce mast cell degranulation. So you can do that with antihistamines. Antihistamines help with the histamine portion of it. There are other medications called leukotriene inhibitors that pharma will get into you with. We've heard of Singulair or Montelukast. That one's specific to stop the release of those leukotrienes. Because I told you guys that leukotrienes last block, they're part of the inflammatory process. They call in immune cells. But what leukotrienes also do is they contribute to that bronchospasm. They contribute to that airway narrowing. So if we give these leukotriene inhibitors, that can be something that can be added on. Do we often do that one? It depends. It depends on the severity of the asthma. You know, if we're trying to treat it with bronchodilators and Flovent or inhaled steroids, and there's just not quite there, maybe we'll add that on. But definitely want to have something for that acute exacerbation of bronchodilator. Definitely want to have something for that chronic inflammation, so that inhaled steroid. And then if we need to, we can add on those medications to kind of step down or reduce their incidence of having that histamine and leukotriene response. So when we talk about asthma, there's two different things we're talking about here. We have extrinsic asthma and we have intrinsic asthma. So you'll see here, extrinsic, we often say if it occurs in childhood and then intrinsic adulthood. For now, just keep that in your head, right? In real practice, can you have a flip? Can you have a child who has intrinsic and an adult who has allergic? Absolutely, like definitely you can. But for the most part, most commonly for this course, I want you to think intrinsic childhood, extrinsic childhood, and intrinsic adult. So with extrinsic, this is that allergy response. This is that allergic response that causes the asthma, right? It's that type 1 hypersensitivity. Most of the time with these kids who develop asthma, it's going to occur before the age of 10. Can it occur later? Yes. Can it occur, a little bit later than that? Definitely, but most of the time it's going to be before the age of 10. Most of the time there's a family history of asthma or some type of allergic, like eczema or allergic rhinitis, because those three go hand in hand. Allergies, atopic dermatitis, or eczema, and asthma go hand in hand. Okay? It's called the atopic triad. What happens here is that you inhale some type of allergen. If you guys remember that picture from last block, we have the mast cell, and it's got IgE kind of sitting on top of it. When we inhale that antigen is going to sit on that IgE and activate that mast cell to release those inflammatory molecules, that histamine, the leukotrienes, the prostaglandins. When that happens, that kicks off that immediate response of that bronchospasm, the mucus production. And so if we can, we'll go ahead and try to do allergy testing. There's different ways of doing it. You can do blood tests, you can do skin tests to try to find the cause for this patient's allergic asthma. Sometimes that's beneficial, especially if it's something that you can control. Like if you do an allergy test on a kid and they have an allergy to cats or dogs and you got a cat or dog, cool, you're the cat and dog and it's fine, most likely. But if they have an allergy to Mount Cedar, which is out here in San Antonio, and if you haven't experienced it yet, it kind of sucks. That's going to be a lot harder to treat, right? Because how can you control for that outside environment? So it may be beneficial to check for what the kid's allergic to or what they're allergic to, but sometimes it's hard to control for that. When we talk about intrinsic, so this is non-atopic, so non-allergy asthma. Again, most of the time this is going to be associated with our adults. And the thing with this is that this is not IgA mediated. There's no antigen attaching to the IgE kicking off that mast cell. What's happening here is that certain factors, cold air, exercise, stress, URIs, certain medications like NSAIDs, can actually activate that mast cell itself. It doesn't need that IgE to actually activate the mast cell. And when that mast cell gets activated, same process starts. It starts to release their inflammatory molecules, which kick off that same process. The thing here is that there's no IgE involved. There's no antigen, antibody on the IgE. There's none of that. It's just something other than an allergy is kicking off this asthma response. So here's a picture of kind of normal airway over here at the very corner. In the middle, this is your asthmatic airway. So this person is they're not having symptoms, right? But their airway is more narrow from that chronic inflammation as it is. And then you kick off something, you expose that person to whatever, some type of antigen, or maybe it's cold air or whatever. That makes that airway even more smaller, which is going to be a lot harder to breathe through as we try to, breathe through that mucus, try to breathe through that narrow lumen. Over here on the right side, that's an example of the allergic asthma, right? So you got your IgE on your mast cell, you got a little cat symbol here that's supposed to represent cat dander, attaches to that IgE antibody, kicks off that mast cell to release inflammatory molecules, and you get this bronchoconstriction and mucus production. But it doesn't matter, either whether it's extrinsic or intrinsic, you're still going to get that same response. Okay? All right, COPD. So COPD is a umbrella term. Go ahead.
So I heard people can like grow out of asthma. Does that mean when they grow up, like they somehow the IG is not responding anymore?
So some children can grow out of asthma, right? Why that happens, we don't know. They think the people who specialize in this, they think that when people have asthma, it's a abnormal response of the immune system. And then as the child gets older, their immune system matures, so to speak. So they're no longer as reactive to those things that typically would cause that. So I've had a lot of patients who had childhood asthma. They still join the military because their asthma is no longer, because asthma is one of those things that you're not supposed to join the military if you have active asthma. And then they get, in the military, they serve 10 years, and they get sent somewhere where their asthma reactive is. So do they truly ever grow out of it? I don't know, right? Because I've seen it where people grew out of it and then all of a sudden something exposed them and they came back. But that can happen. It's just, that's what they think happens. They think the immune system just kind of matures, doesn't get as reactive to whatever caused that initially.
Does it always reactivate?
No, it doesn't always. Because I've had people too who had asthma as a child and they're fine, right? We don't, if we knew like what exactly caused asthma, I think we'd have a better cure for it. But right now, all we know is, why we think why it happens and then how we treat it, but we don't know kind of the initially why is the immune system doing this. Cool. All right, COPD. So COPD is, when you hear the word COPD, I want you to think about two things. Chronic bronchitis and emphysema. So COPD is the umbrella term for these two conditions. Chronic bronchitis is COPD, but emphysema is also COPD, okay? And I'll explain kind of the difference between those. But what happens here, again, it's an obstructive problem. We have either some narrowing of the bronchi or bronchioles, or we actually have damage to our alveoli, which is going to cause issues with that alveoli trying to push that air back out whenever we exhale. Most of the time, this is due to smoking. So somebody who smokes, especially for a very, very long time, this is typically what they're going to develop later in life. There's something called a pack year history, if you've ever heard of that or ever talked to a patient. And essentially, you take how many packs they smoke, right, and times that, so they smoke 1 pack per day, and they times that however many years they've been smoking. So if they have a 1 pack per day for 20 years, then it's a 20 pack year history, right? If they have a 2 pack per day for 20 years, that's a 40 pack year history, right? The higher the pack year, the more at risk they are for having COPD. So, and you'll see, and we'll talk about this here, I think in the lung cancer section. There's a certain period where if they have a certain amount of pack years, so if they have a 20 pack year history, then we'll go ahead and we'll start screening for lung cancer in those individuals. Because tobacco smoking is so damaging to the lung that it can definitely cause COPD, but we also worry about lung cancer. But the thing with COPD is that, I talked about asthma, and I talked about how if you take your asthma medications and you take the albuterol, you can reverse that, right? You still have asthma, but you can open up that airway. With COPD, this is non-reversible. Now, can we give medications to try to open up the airway? For sure. Is it going to open up? Yes, but not fully like an asthmatic would. This is non-reversible. And once the COPD damage begins, it's permanent. Like there's no going back. You can't go back. If you stop smoking, can you delay the damage? Absolutely. But once you have COPD, you're not going back to normal. Now how do we assess these people, right? So one of the things we can do for COPD, for chronic bronchitis and emphysema, is that we can do something called an FEV1. So it's forced expiratory volume in 1 second. In pulmonology, we'll get into this, but it's part of the pulmonary function test or spirometry. And it's essentially what we do to assess somebody's, how well their lungs are working. What we'll do is we'll have a patient breathe in, so breathe in as much as you can, and then forcefully exhale as fast as you can. Forcefully exhale as fast as you can. What we're going to do is in that 1 second, we're going to see how much you can blow out air. If you can blow out 80% of your projected air, then you're normal, 80 or more. If you can't, then that means that there's some type of obstruction going on because something is in the way, a mucus plug or maybe a collapsed bronchiole, something's getting in the way of you actually pushing out that air. So if you have a decreased FE1, less than 8%, that tells us that there's obstruction going on, and then that will kind of help us determine, what we do with this patient and get them the right treatments. Now in reality, I talked about how COPD is 2 components, right? When we talk about COPD in this class, and when we think about COPD for your test, think about them separately, right? Because it'd be hard for me to say, somebody has COPD, and then I give you a scenario, and then which one do they have? So think about them separately. In reality, people are going to have both of these issues. One's going to predominate, so either they're going to have emphysema more than chronic bronchitis or vice versa. But most of the time when people have this, they have both components, okay? So chronic bronchitis, so what this means is that from that tobacco smoke, and that's the most common reason, that causes chronic inflammation of the bronchi and the bronchioles, so the larger airways and the smaller airways. When that happens, we're going to cause a lot of irritation, a lot of inflammation. That's going to cause a lot of mucus production. So that irritation is also going to cause these changes in the wall. That's going to lead to those fibroblasts coming. Remember the fibroblasts? They like to cause fibrosis and scarring. These fibroblasts are going to come in and they're going to go into the airway wall and start to lay down their collagen, which is going to make this fibrosis and make that airway a lot smaller too. So you got this chronic irritation. In your airway, you have cells, goblet cells and mucus cells that they're normally there to make mucus. They're supposed to be there. When you have this chronic inflammation, those cells are going to get bigger and they're going to grow more. There's going to be more of them. They're going to make more mucus. So you have a ton of mucus kind of just filling up those airways, which will contribute to that narrowing. And then you got that bronchial wall thickening, which is going to make that lumen a lot smaller, which is also going to narrow the airway. So imagine you got mucus, you got a narrow airway. You take a breath in. Try to breathe that back out, there's something in the way, there's an obstruction. So that's where this obstructive pulmonary disease comes from, because there's something in the way. With chronic bronchitis, you're gonna get a chest x-ray, you're gonna do your pulmonary function test, but you don't need those to make the diagnosis. So it's what's called a clinical diagnosis. If somebody has these characteristics, they have productive cough for at least 3 consecutive months, in at least 2 consecutive years, that's enough to make the diagnosis. You don't need anything else. Are you going to do other stuff? For sure, because you want to see how the lungs are working. You want to make sure there's nothing else contributing to their symptoms. But all you need is that right there to make the diagnosis of chronic bronchitis. Okay? So emphysema. So different process in chronic bronchitis. So still inflammation going on. But what's happening here is that the air spaces distal, so past that point of the terminal bronchioles, those very end bronchioles are becoming expanded. And the alveoli have walls between them. And I'll show you a picture here in a sec. They have walls between them that contribute to the surface area, that contributes to that gas exchange. With emphysema, you have permanent enlargement of those distal air spaces, permanent enlargement of the alveoli, and destruction of the alveolar walls. Smoking is the top reason for this, but when you have an inflammation, right, what happens? Immune cells come through, they get called on by tissue damage, they come in, certain leukocytes, they release these proteases. And you remember proteases, they like to break down proteins. One of those proteases is something called elastase. Now, do Do you need to know elastase? No, but I think it helps make sense. So a type of protease is something called elastase. In our lungs, in the alveoli, in the septa, and in the terminal bronchioles, you have elastin. Elastin is a protein that helps the alveoli kind of snap back. It helps them snap back, and it helps keep those bronchioles, keep those bronchioles open. When you break down that elastin, think of like a rubber band, right? Rubber band, you stretch it out, it snaps back together. When you break down that elastin, you try to take a deep breath in, if you don't have that elastin in place, what's going to happen? It's going to stretch out, right? And if you don't have that elastin in place, it's not going to bounce back. Does it make sense? So elastin is think of it like a stretchy rubber band. When you start breaking down the elastin, when you inhale, that alveoli doesn't have that elastin to pull it anymore, so it's going to stretch out. It doesn't have that elastin to bring it back, so it's going to stay stretched out. The bronchioles also have elastin in them as well. The terminal bronchioles have elastin as well. When you break down that elastin, so when you breathe out, that elastin actually helps open up those terminal bronchioles. It helps keep them open. When you break down that elastin, now you don't have that piece that's helping it stay open, and so it closes. So you got this big alveoli that's stretched out, can't really snap back like it needs to. You got the bronchioles that have elastin that's broken down as well, and so it can't keep it open, so it's going to close. So you get this air trapping because you got this alveoli that's full of air, it can't bounce back. It can't get past the bronchioles, and so you get this air trapping. So you get air kind of stuck in the alveoli. When you have air that's trapped, and you try to breathe in again, well, you still got air in there. So it's going to be hard for that fresh air to come in, so it's going to decrease that gas exchange. If you can't exhale that air, well, what's left in there is going to go through the process. You're going to take the oxygen out, but what's left in there is there's not a lot of oxygen. There's a lot of CO2 in there. There's not a lot of oxygen. So that when we break down those walls of the alveoli, again, like I told you guys, those also contribute to the gas exchange. When we break those down, we lose that, which means we lose surface area. So now, instead of having those walls that contribute, all we're really relying on is the outside of the alveoli. So we have decreased gas exchange, we got air trapping, which causes that obstruction problem in these individuals. Now there's something called alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is, we all have it, right? We all have it, our liver makes it. Its job is to kind of tamper down that protease release, right? Because we have immune cells that run through our lungs, they're going to release proteases, that's normal, they're supposed to. Alpha-1 antitrypsin helps mitigate that. When we lose alpha-1 antitrypsin, those proteases start to take root. They start to break down the elastin and cause those issues. So in people who don't smoke, they can develop emphysema if they have alpha-1 antitrypsin deficiency. So that thing is very, very important. So if you have somebody who comes in, they're a non-smoker, but they have emphysema, you should think, oh, maybe they have alpha-1 antitrypsin deficiency. You can test for it because that's going to cause it's going to cause emphysema. It's going to cause symptoms like a COPD patient who smokes, but they don't smoke. Most of the time when people have this deficiency, they're going to present with emphysema around 30 to 40, so it's a slow process. It's not going to happen quickly. But if you add on like somebody who has this deficiency and they smoke, well now you can have somebody in their 20s have emphysema. So this alpha-1 antitrypsin deficiency is one of those things that if you see it and they're a non-smoker and they have emphysema, that should be something that triggers you. Think about it. So I included this picture here. It's not in your slides. I threw it in there last night just to kind of make the point. You can take a picture of it, or I can upload it to the Canvas if y'all like. But I want to just show you the difference, right? So down here, you got healthy alveoli. Get this thing to work. So down here, you got healthy alveoli that have those septa, that have those walls. They contribute to the circulation. They contribute to the gas exchange. When you have emphysema, these walls break down. So you still have your alveoli, but they merge. Okay? These walls, without them, they're not contributing to that that gas exchange. So we have less surface area for that gas exchange, so they're not going to be perfusing like they should. On top of that, these walls are these alveoli are very weak because they don't have that elastin. So when you breathe in, this thing's going to stretch out. I'll show you another picture in a second. And when you try to breathe out, they're not going to bounce back, and then these terminal bronchioles, they're going to snap shut. Which is going to cause issues with trying to get that air out. So that's the emphysema, and then on the other side, you got the chronic bronchitis. And I think that makes sense. You have this chronic inflammation, your bronchi and bronchioles. You got this air wall, wall edema. You got mucus production. But again, this is permanent. It's not going to go back if you stop smoking, but it can delay that progress. So here's another picture of that. And I think if you look over here on the right-hand side, I think that picture about the emphysema kind of shows what I'm talking about, right? So air, you don't have the elastin, so that alveoli is going to really kind of get big, branch out, and then it's not going to snap back because you don't have the elastin in there anymore to kind of help it bring it back together. Those terminal bronchioles, they're going to close, which is going to contribute to that air trapping. And so if you're trying to breathe in, because you have that airway, if you have that air still in there, it's going to be a lot harder to get that air in there. So how do we differentiate between the two, right? So there's something called blue bloaters and pink puffers. So blue bloaters are going to be your chronic bronchitis patients, and pink puffers are going to be your emphysema patients. So let's kind of break down the blue bloaters first. So if we look at dyspnea, it says mild, right? So what does that mean, mild? When we compare the dyspnea to a emphysema patient, it's mild. So because emphysema patients they have a very hard time breathing. I'll explain why in a second. What happens here, so they got that chronic bronchitis, right? They got this mucus production. They got this heavy, thick mucus production from that increase in mucus. When they cough, their cough is going to be the kind of the main thing here. Because they're trying to clear out all this thick mucus that's kind of stuck in the bronchi. When they are, if you look at them, they're going to be cyanotic, right? Now, why is that the case? Why do they have cyanosis? Well, if we have airway blockage, if we have this mucus production that that's blocking the air from getting in, whenever they're trying to breathe, it's not able to get past that point of the blockage. Now, if they're able to clear that blockage, the alveoli still work. They're still, blood's still perfusing around them. They're still doing that gas exchange. And so that's why they are mildly short of breath compared to an emphysema patient. Because if we can clear that blockage, then we can still get that gas exchange going and still get the oxygen to the tissues. If you look at their chest, it's going to be normal, and I'll kind of explain what that means here in a second. If you do a chest X-ray, it's non-specific. Now, radiology, I think, is going to get into what you can see in this, but there's going to be all kinds of these non-specific changes, if you will, that can be due to a lot of things, but you could see in a bronchitis patient. Now, when we talk about emphysema patients, pink puffers, right? So their dyspnea is going to be a lot more severe. Now, I told you that with emphysema patients, they're going to have a hard time getting that air out because that alveoli is damaged, because the elastin is gone. So what they're going to do is they're going to have what's called pursed lip breathing. They're going to, when they're exhaling, they're going to make their mouth close or smaller to try to increase that back pressure to the lungs. So when they do that, they're actually able to keep their airways open by keeping that back pressure open, the back pressure into the deep lungs through that pursed lip breathing. They can keep that airway open long enough to try to exhale that air. So that's why they're not cyanotic. That's why they're called pink puffers, because even though they're having trouble breathing, if they do that, they can still oxygenate their blood, but it's just they have to kind of keep that habit, and that's hard, right? So think about when you breathe. Take a breath in, you exhale. You're not doing anything when you exhale, right? There's no work to that. With this type of breathing, you have to work at this. You have to hold your mouth, you have to forcefully exhale to actually get the air out. And so you're using calories, which is why these people are thin. They're doing a lot of work to actually breathe. Unlike us, who just inhale, exhale without any issues, these guys have to work at their breathing, which is going to make them use a lot of calories, which is going to make them a lot thinner. because of that air trapping, because they have trapping of that air in their lungs, they're going to have what's called a barrel chest. They're going to have this kind of big barrel-like chest. So when you look at their AP diameter and the lateral diameter, you know, you guys do that, Clinicals? Because they have that air trapping, their AP diameter, so from front to back, is going to be super wide. When you compare that to the lateral diameter, that AP diameter is going to be a lot bigger than the lateral. So, and that's because they have that air kind of being trapped in there because they can't get that air out like they're supposed to. One thing I forgot to mention with the blue bloaters. So why are they bloaters? Why do you guys think they're bloaters? Yeah, so these guys, the blue bloaters, because I briefly talked about it, I think last block, or cardiology. I told you guys when somebody has lung disease, right, they can have cor pulmonale, which is that right-sided heart failure due to a lung issue. So these guys get that. So when you decrease that oxygen blood flow, or the oxygen to your lungs, what actually happens is that, I think I talked about it, it causes vasoconstriction, which can cause pulmonary hypertension. So when this happens, they're going to get that right-sided heart failure, which is going to cause that edema, which is why they're called bloaters. Can this happen in a peak puffer? It can, but it happens later. It happens super late. So it's not because they're still oxygenating. If they keep that pursed lip breathing, they're still able to get that oxygen in and out. Over time, as those alveoli become more damaged from the continued smoking, then this can make this worse, and that's why you typically see them together. So can the peak puffer get it? Yes, typically later. The blue bloater gets it a lot sooner, so that's why they're called the bloaters from that right-sided heart failure. So here's a picture of somebody with emphysema. So if you look at that normal chest X-ray, right, looks nice and normal. You can see with the diaphragms how they kind of bulge into the chest cavity versus the emphysema patient, they're going to have a flat diaphragm because you have all that air trapping. That air is being trapped, and so when you take that deep breath in and you try to exhale, you can't get that air out, so that diaphragm is going to be a lot flatter. That chest is going to be a lot wider, and I'll show you this picture here. So that AP diameter is going to be bigger than the lateral because you have all that air trapping. So this is typical with emphysema patients. Again, the chronic bronchitis doesn't look like this, but can you have a mix of this in real life? Yes, you can, but this is really particular for emphysema. So here is, so this is talking about smoking, right? So we said smoking is the most common cause for COPD. So if we look at this graph here, and you got a 25-year-old patient, and we're checking their FEV1, we're checking how much air they can breathe out in 1 second. At 25, we're saying that they can breathe out all their air in 1 second. As that person who never smoked, so this is a non-smoker who never smoked, as they get older, naturally your FEV1 is going to decrease. As we get older, things start to break down, start to wear down. So naturally it's going to start to get a lot lower. Now if you have a smoker, and they're smoking, well, they can't get their FEV1 all the way out because they're smoking. And if they continue to smoke, by the time they're 60, well, I guess at 70, by the time they're 70, look how much more of a decrease you get versus the non-smoker. Now, if you go back up to that 45-year-old person, if they stop smoking at 45 years of age, they already lost that lung function. They already caused so much damage that you're never going to go back to that normal FEV1 as if you never smoked. But they can delay that process. So you can, if you stop smoking now at 45 years old in this scenario, you can delay the severity of this disease. If you don't, then you're going to lead to more damage. It's going to cause disability. When we talk about disability, this is just like problems with the daily activities, like going for a walk or playing with your kids or something. So the sooner you stop smoking, the greater you are at reducing that risk of chronic long-term problems. All right, let's take a 10-minute break.
She like flying or something?
Oh, yeah, she was like, it wasn't a lot. She said she's gonna do it. Yeah. I guess they've been charged for it. I'll say this.
Well, they're similar, but not the same.
I think it's synonyms.
Angry and mad. Angry.
Well, if you also think about it, mad also used to not only talk about anger, but also crazy.
I'm mad.
So
Both ways.
I think anger
Either or works.
Anger just means that you're
But
upset
angry.
versus are you happy? That's true.
I can be mad at you.
That's true.
Like, if I'm angry,
You still talking just very with the sharp tongue. So I'm not angry, but really I'm not angry.
See, that's the first.
that's me.
That's the first.
I don't know, I think
Like when you're angry, it's like, well, I really thought, I really thought you were see, I really thought you
I'm like this all he has no soul, he's like an old man.
I feel
He likes his salted meat.
you like that's like salty. You ever know that like guy on like got the chance
I got into neither of them.
My wife did not want to wait till she finishes. She wants to but she's also bored because I'm down for it. She doesn't want hopefully she gets to
So we're gonna kind of switch and start talking about some basic authority services. somebody asked me, I
Oh
didn't,
my
I
god,
didn't
I
catch
was
this
like,
actually.
this is like a.
So there was a slide, or, I took out bronchiectasis, so we're not talking about bronchiectasis. In the previous iteration of this course, they had mentioned that COPD was they included bronchiectasis in COPD. That's not accurate, so I took it out just so we don't get confused. Can you get bronchiectasis? Pulmonology will get into that with you. It can, but it's not a component of COPD. Like you have chronic bronchitis and you have emphysema. So mark that out and just save that to pulmonology. All right, so atelectasis. So atelectasis means that the alveoli, those alveoli, they can't open all the way. If they can't open all the way, what can happen is that they can collapse. When they collapse, they're no longer contributing to that gas exchange. Okay? You're going to see atelectasis. Atelectasis patients, people who are sick, who have trauma to their chest, or who break a rib, they don't want to breathe in all the way, or they can't breathe in all the way because maybe there's some blockage, right? So if you don't get that alveoli to expand to when you're breathing in, it's not going to open, and as a result, it's going to collapse on itself. And that piece, that part of the alveoli, is no longer contributing to blood, that gas exchange. It's closed, right? Now the thing is that if you have atelectasis and you fix the problem, whatever caused it, then your lung will open back up, and then the patient's fine. Patient's fine, they can breathe. But you have to identify the cause and fix it. So poor chest expansion. So look at there, we got patients unwilling or unable to breathe deeply. This is very, very common in people who have some type of chest trauma. Rib fractures this is very, very common in rib fractures. Has anybody been to the UK, lived in the UK or no? No? Yeah? Okay. So in the UK, when you get out to the country, those roads are like one-lane roads, and they look like they were built whenever the UK was founded, because they're very old, they're through farm country, so, and then you're driving on the opposite side too if you're an American, so it's kind of weird, right? So anyways, I had a patient one time. He was driving through one of those UK roads in the country, and something came out and he flipped his car, because those roads are super windy. He flipped his car, had a lot of body damage, broke a lot of his ribs, and then was inpatient for a long time, and then finally he got released. His ribs were still fractured, and he came and saw me. And as we were following him, just making sure that he was getting better, we would get chest x-rays periodically, and I would see that he had atelectasis. So because every time he tried to take a deep breath in, it hurt him. He had a lot of pain, so he couldn't fully expand his chest. And as a result, he started getting these atelectic spots like at the lower base of his lung. So what you can do for stuff like this is you can give them that incentive spirometry. I don't know if you've ever seen that where a patient kind of blows into this device and they're trying to push this ball up to a certain region. That really is just there to try to get them to open and exhale and inhale forcefully to try to open up those spaces. That way they can contribute to the actual gas exchange. But very, very common is somebody has some type of chest trauma, rib fractures, then you worry about atelectasis. But like I said, once this patient gets better, ribs start to heal, pain eases up, and you make sure that they're doing things to try to open up those airways, they're going to be fine. If they have restriction of lung tissue, we'll talk about some of these here in a second. Sometimes you can get these diseases that can cause scarring and fibrosis in the lungs, and so if you have a scarred lung, it's not going to expand easily because it's scarred, and so you can develop atelectasis there. Or it can be some type of tumor, some type of cancer that's blocking the airway, and so you got this mass that's getting in the way of one of the alveoli or multiple of them. You're going to have this kind of spot in the lung, and then the rest is going to be kind of this white appearance because there's no no airflow getting through that. Something else that could happen is that if you have some type of bronchial blocking, so your COPD, your chronic bronchitis patient, if you have blockage in that bronchiole and you can't get air out, what's going to happen is that the air that's stuck in there, it's going to start to get reabsorbed by the blood. And so you'll see with these patients that they got this blockage, whatever it may be, air can't get out, and so as the blood flows through, it's pushing out CO2, it's pulling in oxygen, but that CO2 can't get out, there's no more new oxygen coming in, so that CO2 is going to get go back into the blood, and then eventually that alveoli is going to collapse on itself. So that's the resorption of air. Now there's something else called neonatal respiratory distress syndrome. So in these babies, right, if they're born premature, there's this substance that we all make. It's called surfactant. Surfactant, our lungs make it, and its job is to help keep our airways open. Because our airways, they're full, or not full, they have a thin fluid kind of membrane. In that fluid, you have water molecules. That water molecule likes to attract, right? Water likes to attract to each other. So if it wasn't for this surfactant, that water would attract to each other and actually cause that alveoli to collapse. And so if a child is born prematurely, they're not making enough surfactant yet, so we worry about this because if they don't have that surfactant to kind of break up that tension, then their airways are going to collapse and develop atelectasis. Now, most of the time we're able to treat this. We actually can give surfactant to a premature child. We'll do other things to kind of keep the airway open, but that's one of the things we worry about is that if those airways close, they can develop this neonatal respiratory distress syndrome due to the fact that they're not making enough surfactant. So surfactant is super, super important. So here's an example of that resorption atelectasis. So you got that blockage, right? And air can't get out, air can't come in. As that blood kind of moves along and it starts to flow, it's pulling that air back into the blood. Eventually, as that air gets pulled enough, it's going to cause that alveoli to close, to collapse, which is called resorption atelectasis. And here's what this looks like on chest X-ray. So you can see here, at the very top, doesn't look too great, but it's not terrible. Now you kind of progress down, you see that that right lung just trying to, or left lung, start to close up because there's no airflow going through, so those alveoli are going to start closing up, causing that atelectasis. All right, acute respiratory distress syndrome. So this is one of those things that is super, super dangerous, right? Something happens to the body. It could be some type of burn. It could be some type of septic shock. Something damages the lungs, the alveoli, or the capillaries. If you inhale, if you're involved in a fire and you inhale, hot air, it's going to damage the alveoli. If you have septic shock, we talked about septic shock last block, and you have this release of these molecules from the bacteria that start to cause your body to go into vasodilation, that can actually cause the capillaries to start to expand, and it can cause that fluid to actually leak into the alveoli. When that happens, that starts the inflammatory process. When that inflammatory process starts, it starts to damage the alveoli, and it starts to damage those cells that make that surfactant. So now you got fluid filling the alveoli, you got this damage to the cells that make surfactant, and as a result, you got this impaired gas exchange. You have fluid in there, you don't have the surfactant anymore, and so those airways are trying to close. At the same time, they have a lot of fluid in them, or maybe blood, depending on what's going on. And so there's no gas exchange going on anymore because the airways are collapsing, or they're filled with so much fluid and blood and trying to collapse at the same time that you can't get that gas exchange anymore. When this happens, this is usually going to happen usually 24 hours after an initial injury. It can happen up to a week, so it's an acute process, 24 to 7 days. And these people are going to have a really, really hard time breathing. They're going to have severe distress, severe hypoxia because there's no gas exchange going on. They're going to be very, very short of breath. And because of that inflammatory response, you're going to get this severe pulmonary edema bilaterally. With these guys, you can't just treat them with oxygen and say they're good to go because you got this fluid in there, you got this surfactant that's not being produced. So most of the time, they're going to need intubation and some type of ventilation. But because you have all this, stuff, this crap in the lungs, when you ventilate this patient, you have to ventilate them with a high pressure. You have to push that air in there. And it's kind of like a teeter totter. If you give too much pressure, you potentially pop that alveoli. So it's one of those things that you got to be super, super careful with. Make sure you're trying to push enough air in there as much as you can without overdoing it because it can cause trauma to the alveoli and cause it to rupture. This high positive pressure, so again, you're pushing air in. Now, when this ventilator is actually breathing for the patient, we're still trying to keep those alveoli open because if we fully exhale for the patient, then we're going to cause that collapse. So even though we're pushing air in, whenever we exhale for the patient, we're still keeping a little pressure in there to keep those alveoli open. So that's what that means. Now, if that doesn't work, then we can do something called extracorporeal membrane oxygenation, ECMO. Essentially what this is it's like a device that you hook up to the patient, it takes their blood, and it breathes for them essentially. Like it oxygenates their blood. It doesn't breathe actually, but it oxygenates their blood. So it goes to this, so their blood goes to this device, it takes out the CO2, puts in oxygen, and then we put it back into our patient. And I used to actually do this, I didn't do this, but when I was a blood banker, when I worked at SAMC, we used to give a lot of blood because this device, even though it's taking the patient's blood, it can actually consume the blood as well. So we'd have to give a lot of blood when they would do this device because back during the wars, right, there were a lot of people who were coming to SAMC because there was a lot of burn trauma. And so they would be on the burn ward, and they would have this ECMO procedure because they had all this damage in their lung airway, and so we would give a lot of blood to these folks because of how severe they had this lung injury. Now, regardless, right, once you get to the ECMO status, chances are not good. And I encourage you guys to just quickly look at a YouTube video on this because you'll see it's not one of those, here's some, stick this to a location and just get the blood. It's a very, very in-depth procedure. But, when they have this, their chances of surviving are very, very low. So here's an example of pulmonary edema, but with ours. So look how severe that is. I mean, it kind of almost just completely wipes out the lung. That's how much fluid, edema is inside the lung because of all that tissue damage that's going on within the alveoli and potentially the capillaries if it's some type of septic shock issue. So pneumoconiosis. So thankfully, these are kind of rare, I would say, but they definitely still happen. So pneumoconiosis, something foreign is inhaled to our lungs, right? Could be dust, could be fumes, could be coal, could be a lot of things. There are certain diseases that are associated with certain things we inhale or potentially could inhale. So coal workers' lung disease, kind of, it makes sense. People who work in coal mines or work around coal inhale these carbon particles from the coal, which actually can accumulate in our interstitial part of our lung. When that happens, that creates a lot of inflammation because our white cells are coming in trying to destroy this foreign body. They release their inflammatory molecules. They call in the fibroblasts. The fibroblasts lay out scar tissue, and so it causes a lot of scarring in the lung. When that happens, when you have a lot of scarring in the lung, scars are restrictive, right? They're restrictive, and so when you try to take that deep breath in, you can't anymore because you have all the scar tissue. It's going to cause a difficult time with lung expansion. You try to breathe in because that scar is in there. It's not letting you fully expand your lungs. As a result, you're not getting that adequate oxygenation. Silicosis, this is associated with mining stone workers, cement workers, and bricklayers. So think about your people who work with stones, right? Or your people who, if you have a house and it has quartz in it, right? That kind of stuff, that type of stone material. If you inhale that stuff is super toxic and it kills our macrophages, right? It kills the macrophage tries to eat it, but it's so toxic that it kills the macrophage. You worry about TB with these folks because TB we talk about how macrophages cause those granulomas, right? They try to eat that TB and then try to make a wall around it. When you take out the macrophage in the lung, now you're at an increased risk of TB. They also cause scarring in the lungs, but they do a little bit differently. So with the silicosis, it doesn't kind of just sporadically hit the entire lung. It goes to different spots. And as it goes to different spots in the lung, you get these nodules of fibrosis. So nodules of scarring. Those nodules can actually come together, coalesce, because other tissue is damaged, so you get something called a fibronodular lesion. So I'll show you a picture here in a second. So you got these kind of patches of these scar tissues in the lung, but still the same process. You still have scar tissue in the lung, you still can't take a deep breath in because of that scar tissue, and as a result, you have trouble with gas exchange. And asbestosis, this is probably something we're all more familiar with. They don't really use asbestos anymore. They still do in some situations, but that's one of those old things. But still, if a person was exposed to asbestos, shipbuilders, construction, manufacturing, those particles are very, very fine. And when they get into the lung, again, our macrophages try to come, they try to eat those, but they can't. They can't destroy it because it's a foreign body, right? And so they release their inflammatory molecules, and the same thing. With asbestosis, that's that scarring of the lungs. You still get that inflammation, you get that scarring, and you still have that difficulty with expanding your lung. Now, mesothelioma is different than asbestosis. It's still related to asbestos, but it's different. with mesothelioma, you get a cancer in the lung pleura. So you shoot a chest X-ray, you see this mass in the outer aspect of the lung, and that's in the pleura. And so that's what mesothelioma is. It's a cancer of the lung pleura. So different. So asbestosis is fibrosis, the scarring. Mesothelioma is that actual cancer of that lung pleura. Still caused by asbestos. So here's an example of that. So coal worker, and you can also get something called black lung because of that coal that builds up. But you get this fibrosis, the silicosis, you see these fibronodular kind of scarring throughout the lung. And then with asbestosis, you get scarring in the lung, but the mesothelioma is that cancer piece of it that can happen with it. All right, moving on to cancers. So laryngeal carcinomas. So cancer can develop in our larynx, right? And there's several ones that we care about. Now these are all FYI, right? You don't have to worry about where these occur at, but you still need to know about laryngeal carcinomas. So if they occur in our glottis, if they occur on the actual vocal cords, that's the most common. That's the most common, cancers of that area. And it's actually a good thing if it happens there, because if it happens there, these patients are going to have trouble talking, they're going to have hoarseness, they're going to have some type of change in their voice. When they have that change in their voice, they're going to come see you, and they're going to say, hey, I'm having, I have a raspy voice, I have a hoarse type voice. You ask when it happened, they'll tell you, right? But when that starts to affect the actual vocal cords, patients are typically going to come in to see you, and then you get their history, and if they're a smoker, if they're a drinker, remember we talked about smoking and drinking are very, very bad. This should kind of lead you to think maybe they have some type of cancer of their actual vocal cords. The problem with the supraglottic and the subglottic tumors is that thankfully they're rarer, right? But they're not occurring on the vocal cords themselves. They're occurring above or below them. So with the supraglottic, a patient may have this and not present until later when it actually starts to locally invade the vocal cord. And by that time, you worry about metastasis because they've had this cancer for so long because they didn't know they had it. Maybe they'll have trouble swallowing, maybe, but they're going to present later because they're not having those changes to their voice that's going to trigger them to come. Versus the subglottic, again, this is below the vocal cords, so they're not going to have those changes to the vocal cords unless it starts to locally invade that. Typically with the subglottic, they'll have if it actually starts to cause a massive, they'll have trouble breathing because of where that's where air enters through. So thankfully, glottic tumors are more common because of that, because they have symptoms initially right off the bat, we can treat those a lot easier. But smoking and drinking, very, very bad. Also neck radiation, so if you have to CT somebody's neck for whatever reason, CTs aren't they're not benign. You worry about this later in life, so you gotta think, is this worth doing a CT? Is there something better I can do? Because if they're exposed to radiation, maybe they're not gonna have cancer tomorrow, but years from now, they can predispose them to developing these types of cancers. Painless lymph node, we talked about that already. If somebody has a painless lymph node, think about cancer. But if somebody has this, we're going to get them over to ENT. ENT is going to do their thing. They're going to cut out that thing. Especially good chemoradiation based off how much that thing is spread. Don't worry about this grading thing here. I'm not going to ask you about that. All right, lung carcinomas. So lung cancers, right? So obviously smoking, we know smoking causes lung cancer. We know that. We've known that for a very long time. That 20-pack year history, right? If somebody has a 20-pack year history, they smoke for 20 years, 1 pack per day, that is a very, very, that greatly increases their risk of developing lung cancers. So there are actually guidelines out there, USPSTF, you guys heard of that maybe? If not, you will next time. There are actually guidelines out there that say if somebody has a 20-pack year smoking history, we actually do a low-dose CT scan of their lungs to try to look for lung cancer because of that risk of smoking. It's actually one of those preventive things that we'll do. If you have lung cancer, the chances are good that you're not going to survive for a very long time because lung cancer presents very, very late. And by the time it presents to you, most of the time this person is going to have metastasis. And it's still the leading cause of death. We talked about that last vlog. It's still the #1 cause of cancer-related death in the United States. Now there's different types of lung cancers. We have small versus non-small cell cancer, right? Pulmonology is going to get into all the lung cancers with you, and they're going to talk about each one individually and kind of tell you, the difference between them. Really, really, I want you to focus on the small cell because they are the worst. If you have small cell lung cancer, this is gonna rapidly metastasize, and if you don't catch it, which most of the time we don't, this patient's probably going to not live for a very long time. With this small cell lung cancer, with really any cancer, but with small cell, you're gonna have that cough because that small cell actually forms in the bronchi. And then it can actually go into our lung tissue itself. When you have something in your bronchioles, your bronchi, what do, right? If you actually inhale something, you'll cough it up, right? These guys are gonna have this persistent kind of nagging cough. They could have bleeding, especially if it starts to erode to those blood vessels, so they'll have hemoptysis. You're gonna have trouble breathing because as that cancer starts to block that bronchiole or starts to invade that lung tissue and starts to destroy it, you're gonna have dyspnea or worsening dyspnea. And then here we go to paraneoplastic syndromes, right? Paraneoplastic syndrome. So lung cancer, small cell lung cancer can cause paraneoplastic syndromes. Small cell lung cancer can release something called antidiuretic hormone. Antidiuretic hormone is made in our hypothalamus and then it's stored in our pituitary gland. And its job, normally, we make this normally, its job is to kind of sense our blood, kind of see if it's too concentrated, if it is, it releases this hormone that tells our kidneys to hold on to water, okay? And most of the time, like if you're dehydrated, if you're vomiting, that's when it will kind of do its thing, right? If you have somebody who is, doesn't have any of those risk factors, and you draw their blood, and they have hyponatremia, they have a low sodium level, that means that maybe they could have, it could mean a lot of things, right? But maybe they have a paraneoplastic syndrome because their lung cancer is actually releasing this antidiuretic hormone. And as a result, we're going to hold on to more fluid, which is going to dilate our blood, so to speak, which is going to cause our sodium to be a lot lower than normal. That's how that could present. Make sense? Okay. So here are some pictures. So that one on the left, that's that small cell. Again, typically starts centrally, typically in the bronchi or bronchioles, and then it starts to spread out to the lung tissue. Versus the other ones we talk about, adenocarcinoma typically occurs in the periphery of the lung. Squamous cell can occur centrally as well. But again, small cell is what you guys need to know about because of how aggressive it is if somebody has this. They can do, especially if it's in the center of the chest, and especially if it's growing in the bronchi, then we can do something called a fiber optic bronchoscopy, where we actually stick a tube into the person's trachea, and then we can find that mass, take a biopsy of it, send it off to pathology, and they can tell us what type of cancer it is. If it's out in the periphery, that's a lot harder to do, obviously. So typically what they'll do is just kind of go through the chest wall and take a piece of it that way. If it's central, then we can kind of avoid that risk of that pneumothorax potentially, and just go into the trachea itself. So, with lung cancer, right? So small cell is a primary lung cancer. It forms in the lung. That's primary. It's more common to have lung cancer from some type of metastasis, though. So primary definitely can happen, but if you see lung cancer, most of the time it's from metastasis from somewhere else in the body. Could be the breast, could be the GI tract, could be anywhere. And as that blood flows through, and those cancer cells escape and hitch a ride into our blood system, our blood is filtered, so to speak, by our lungs. If they get into those small capillaries and they go into our lung tissue, that's when we start to get these metastatic lesions. And notice down here below, we got these things called cannonball lesions, right? They look like little small cannonballs going off in this person's lung. Primary lung cancer is going to be typically just one type of abnormality in the chest. With metastasis, you're going to see multiple lesions in the chest. That's going to help you differentiate between metastasis versus primary lung cancer. So multiple lesions, think metastasis, one lesion. Typically, it's the primary cancer that formed in the lung. Cool. That was it. Questions for me?